today we have gathered here to attend Manthan meeting, sir, which is Pfizer Oncology's initiative in hematology, sir. So today's our topic for Manthan meeting is transforming the treatment paradigm for patient with relapsed or refractory adult B-cell ALL, sir. So today we have eminent speakers and faculties with us, sir. So I will introduce first, sir, and then hand over to Sanyal, sir. So prior to that, sir, I will read the disclaimer from Pfizer that this meeting is exclusively for invitees only. If you have not been invited by Pfizer in this meeting, we request you to kindly log off the meeting. Initiator reserve the rights to block unintended recipients. A video and audio recording of this WebEx meeting is strictly prohibited. So we are very fortunate enough to have Dr. Shubh Prakash Sanyal as moderator in this meeting, sir. Sanyal sir is a director and consultant hematologist and BMT physician attached to Fortis Hospital, Mumbai. Sir has completed his DM clinical hematology from Seth GS Medical College and KM Hospital, Mumbai. Sir has started bone marrow transplant program in Fortis Hospital since 2014 and completed more than 75 successful transplant, including pediatrics. Dr. Sanyal stood a privileged fellow of Vancouver General Hospital, BC Cancer Agency, Vancouver, Canada, in leukemia, BMT, and lymphoma. Dr. Sanyal having various national as well as international paper and case presentation. Then we have Vinay Vora, sir, who is an esteemed panelist for this discussion. Sir is a consultant hematologist. Sir is MD Medicine and DM from Institute of Hematology and Transfusion Medicine, Kolkata, and is a fellowship in leukemia and bone marrow transplant at Vancouver General Hospital, Vancouver, Canada. Sir is currently working at CHL 114 Hospital, Indore. And Dr. Vinay sir is the first hematologist who started performing BMT at Madhya Pradesh. Sir has more than 10 publications in national and international level and won many prizes during conferences and academics. Sir is also affiliated to ASH and ISHBT with the lifetime membership. Then we have Dr. Debendu Day. Sir is consultant hematologist and bone marrow transplant specialist at Balco Medical Center, Raipur. Sir is DM hematology from Kolkata Medical College. Sir has worked as a consultant as a hematologist in various hospitals like Singapore General Hospital, CMC Vellore, and Mission Hospital, Durgapur. Sir has experience in clinical research, audit, study, conference presentation, and publication. And sir is certified to European Hematology Association. And sir, this will be our agenda, sir, for the meeting, sir. So now I will hand over mic to Sanyal, sir, for moderation. And over to you, Sanyal, sir.
Thank you, Nishant from Pfizer. I think Vinay and Debendu was always a very nice to have the panel and the nice chat we have for the last 30-40 minutes, coming 30-40 minutes. Yeah, you just share the screen. Yeah.
Yes, sir. I am just sharing.
So what we'll do just to chat that how we handle the relapse setting of the ALL, particularly the adult ALL, and what are the options we have in the current situation, and what is your practical experiences, what you do actually. So I remember, I think 2021 MHG meeting, I presented that relapsed refractory ALL, and in our MHG meeting. So when I prepared the lecture, I found one very interesting data that in India, 90% of the relapsed refractory ALL patients are actually go to straight away palliative care. Only around 10% patient get some form of treatment here and there. So that is the whole thing about that. So it's a very dismal thing. So adult ALL itself is a difficult disease, 30 to 40% curable, that not beyond that point. And among the 30-40% curable disease, when it relapses, the situation becomes further very much dismal. So that is the whole thing. So next. Yeah. So Bina, I first come to you. Just two simple questions. So how many patients do you see? Because this data, the company persons also need that to understand that how the things will be moved in the coming future. So Dr. Binay, how many patients do you see for adult ALL in a year, more or less? But
Right,
I
sir.
just exclude the pediatric 1 to 10, then 10 years beyond.
So maybe around 25 new patients a year, adult patients. So adult, I would define probably as those who are more than 25, because I'm really not sure. Pediatric
Yeah,
would be
so
less than 18.
strictly speaking, adult ALL is more than 40.
40. Okay. So because
Then
I think 18 to 39 would be AYA,
correct.
adolescents and young adults. So more than 40, in that case, I would say probably 15 to 20 patients a year, new patients.
Yeah. So I ask you a little different question. Suppose say 2025. So among this percentage, how many percentage actually upfront manages to take treatment?
Only 50%, sir. 50 to 60%.
I think it's a very fair, very honest confession. What is the proportion of relapsed refractory adult ALL in your setting per year, approximately?
I think, sir, almost 50-60% would relapse during their maintenance, in spite of the fact that you give them whatsoever pediatric protocol which we are using, BFM, say 2002, and we try to maintain the dose intensity. In spite of that, I think 50% would relapse during maintenance.
Yeah, fair enough. Dipendu?
Hello.
Yeah, Dipendu, can you hear me?
Yes, I can hear you. Can you hear me?
Questions, yeah.
Yes. So in our centers, we see actually more of the pediatric patient than adult, and I would say around 30 patients of adult ALL in last 1 year, and adult means above 18 years actually. So probably above 40 years, much less, maybe 10 to 12 patients adult ALL, and of that, probably around 60 to 70% patients actually take some treatments. Not that they are going out, but obviously few patients they are there who actually cannot complete their treatment because of the financial conditions, and around 50 to 60% patients eventually relapses after some point of time.
So one thing is very important, what Dipendu told, I think very nicely, that many patients can't complete because the treatment of the ALL is very lengthy. Treatment of the ALL is very lengthy. Like AML, 3 to 4 months you are done, whatever the scenario is. But here you treat at least for 8 to 9 to 12 months, and then 2 years of maintenance. Almost kuch na kuch karke 3 years to ho hi jata hai, yeah, like that. So which is not a very easy for many families to manage. So that is one very important thing. Vinay, you agree with me, no, this point?
And one more addition here. I think those hospitals where there are government schemes, or if they have insurance covers, there probably more number of patients would be inclined to take treatment. Otherwise, when patients have to pay out of their own pocket, almost 50% would not be taking treatment.
You know, Vinay, it is little different. So when the patient is getting free schemes and everything, no, there is also significant number of defaulters are there.
Right, that is true, but at least they would start the treatment.
Yes, that is the same thing because of the financial, that's the government schemes are there. So most of the patients actually starts treatment, but eventually some of them do not complete because they ultimately they thinks that the journey from their hometown to the hospitals, because of the long treatments, they have to stay there, and there are a lot of complications in between. And that point of time, they get depressed and they not continue at some point of time. So that's what happens, even though they get a free treatment.
So initial enthusiasm is there for a few months, and then the enthusiasm starts declining. So that is, I've seen a lot of families and everything. And one more thing, I'm very honest to you, you have to say that who is getting the treatment? Head of the family is getting treatment, one way approaches happens. The single male, who is actually the main income source, who is getting the treatment, whose approach is different. When some housewife is getting the treatment, obviously there are a lot of changes, lot of difference we can see. So it's a lot of very complex thing, not a very easy thing. Yeah, next slide. So this already we discussed a lot of times. So next. Yeah. So we all know that AL cure rates decreases with the age. More the age goes up, the more complexity happens, more comorbidities, more cure rate decreasing. So that is the average. We all know that whenever we counsel about that adult ALL, we call about that around 1/3 patient cure and 2/3 patient don't cure. That is the way. So anything else, Dibendu?
It's the same, but probably our data is not that much rosy one, because most of the time, especially in adult ALL, most of the time the prognosis is not very good actually. And we find that most of the patients after initial treatments, when they are not going in a proper way or the relapses are there, then they go directly into the palliative care, and probably a long palliative care is what they get in most of the time.
So when you talk with your counseling, you give maximum 1/3 cure, right? 30% cure, right? Yeah, perfect. Bina, anything different?
Sir, agree with this.
You agree, no? Yeah. So next slide. So now the very basic thing, it's a Pfizer meeting, so anatosam will definitely come. So Binay, what are the diagnostic tests? That I'm not asking again. So my simple question: when your hematopathologist do the flow cytometry, so CD22 is incorporated in the panel? Or you have to...
Yes, I think, sir, it is incorporated.
It is incorporated. Very good. Dibendu, yours?
Yes, CD22 is actually incorporated from the very beginning, but probably because of availability of anatosam, we are more looking into that factor, whether CD22 is positive or not.
Yeah, so it is our hematopathology is very well tuned. Actually, today only one patient I got from Ahmedabad. Flow was done, but CD22 was not done. So I have to again send the flow from peripheral blood to just only for look for CD22. Because if you miss the baseline, then it's a problem.
Yes.
So that is the thing. So CD22 should be bad. Most of the hematologists are following that. Hematopathologists are also knowing this thing, so they are doing that. Yeah. Next. So I'm not going into the diagnostics test. Dibendu and Binay both are the champions, so everything is very straightforward. Yeah, next. So now, Binay, I have a very specific question to you. How many percentage of patients relapse within the first year of diagnosis of B-cell ALL, adult ALL? So you just divide between two. So you say 18 to 40 and 40 plus. You just answer like that. Approximate your experience. Yeah.
Okay. So I think 18 to 40 within 1 year, probably 10%, not more than 10-15%.
So I want to more specific your question. So I want to understand. So you see many patients relapse when everything is finished, started maintenance, 3-4 months of maintenance, you get a relapse, right? That is
so in my experience, most of the early relapse would be once we start them on maintenance, they are into maintenance for say 6 to 8 months, and then there will be relapse.
Perfect.
Most of the patients would not relapse during that intense chemotherapy phase. Very rarely it happens that they relapse during intense chemo.
Dibendu?
Yes, similarly, during the initial chemotherapy periods, they do not relapses, but we find that because we are now looking at the MRD data, so we find around 30 to 40% patients, they are actually MRD positive. So even though they are on treatment, and those patients, actually, we are not looking into the correlation of whether MRD positive are getting relapse or not. I don't have that data, but around 50% patients, they relapses probably after starting the maintenance therapy within 3-4 months.
3, 4, 5 months. What Binay told. That was 6 to 8 months. I was saying, yeah. Binay, one more specific question. Do you use rituximab in adult ALL for 40 plus routinely in your practice? Or what
No, sir. I am not routinely using it, sir. No, sir.
Okay. I also don't use. I'm very honest to you. Dibendu, yours?
No, I have not used it.
So we are all three in the same page. I know there are the NEGM data and the publication, and the people say that if you have only 30% curability, why don't you try everything together? So there is a logic in that, but honestly, I'm not yet convinced yet. Yeah, so all three in the same page. So what is the most common site for the relapse in your practice, Dibendu?
Most of the time it's the bone marrow relapse, and very few are there who are having a CNS relapse, and mostly they are either CNS relapse or both CNS and marrow relapse. And mostly in the Philadelphia positive patients, we find more of a CNS relapse than bone marrow relapse.
So Bina, you agree with this?
Yes, sir. So mostly medullary relapse. And in my practice, I've seen few patients having isolated CNS relapse, but these were Philadelphia positive patients.
Nishant, if you don't mind, can we divert little from the slides, few discussions?
Sir, all yours, sir.
All yours, okay. So Vinay, I'm coming to straight to you. So I'm sure you are using BFM, right? BFM protocol,
Right.
most.
Yeah.
Yeah.
Yes, sir.
So so suppose a 42-year-old ALL, induction phase 1, you treated, and the MRD is there still positive after induction phase 1. What do? You go with the induction phase 2, or you think about changing the protocols?
So, sir, that would probably it's very, although question is very straightforward, answer is very difficult. That would depend on many things. Number one, whether patient is a transplant candidate or not. Number two, what is the MRD positivity?
Patient is transplant candidate. Chalo.
Okay.
Yeah, 42. Finance is not a problem.
pH negative.
pH negative. Yeah, we'll be discussing more pH negative mostly. Yes, pH
Okay.
negative.
So, sir, in this patient, if MRD is, so if it's a low positive MRD,
Yeah,
I would give induction 1B and then repeat MRD again.
Yeah. So induction B you did. It is still low positive MRD.
I would switch to HR blocks. I would classify this as high risk and switch to HR blocks.
Yeah. Okay. And you see after the 3 HR block 1, 2, 3, how is the MRD, and then you decide. Yes, correct. That is a standard BFM 2002 says like that. I agree with you.
Right.
So augmented BFM arm, whatever you call. Depending, what is your thought process?
In our center, actually, because we try to go for transplant. So if the patient is a transplant candidate.
Next second. So induction phase 1, 42-year-old male, you given, according to Bino, is a low positive MRD is there. End of the induction phase 1, what you do?
Yes. So if it is a low positive MRD and the patient is in hematological response, then we'll continue the chemotherapy as per HR block. But we will try to look in.
So you move to, after induction phase 1 only, you move to the HR block.
Yes, we'll go into the high risk pattern, high risk protocol. But
I think my understanding, I agree with more with Binay, because what Binay says that, because we know there are a lot of late responders. So if you know the high risk block VFM, generally induction phase 1 followed by phase 2, and then you can choose the HR block.
Yes,
yes,
and
because
also
HR blocks are very toxic. The adults toxicity.
So 1 and followed by HR 2, and then induction phase 1, induction phase 2, and then HR block.
Right.
So in the high risk group also, because it is a induction 1A, 1B, and then HR block. So in the high risk protocol also it is the same.
Yes, so that is the same thing I'm telling. Yeah, same thing I'm telling.
So same. So, but we always plan for the high risk protocol from the very beginning when the MRD is positive.
Honestly, what I do, I do different from here. So I follow induction phase 1, I follow the induction phase 2, and still after induction phase 2, there is a disease, but it's coming down disease. MRD is coming down. Then we use the methotrexate and the 6 MPa block, but there methotrexate we give 5 gram per square meter. What Binay told, I fully agree, because initially we used to do high risk block, and I have seen lot of toxicities in the high risk block, because high risk block is 1, 2, 3, and again 1, 2, 3. So there is 6 block, and there are recent data that high risk block actually do not give much weightage when the other newer drugs are available, like blinatumomab and anituzumab, all are available. So recently there is a hematology cancer consortium. So what is a very nice thing they told, that that's a very nice discussion. Honestly, Dr. Chandran told me this personal thing, because Chandran was a part of the team. Induction phase 1, phase 2, and then you go for the methotrexate phase. Your MRD negative, you treat like your Gillette induction phase 1 and phase 2, and then maintenance. And if it is positive, then do something to make it negative. Do something to make it negative. Now you decide what something you want to do. You want to go to high block, whatever high dose blocks. You want to go single agent blinatumomab, you use single agent anituzumab, but do something to with the MRD negativity, and then go for transplantation. I ask this question in little different way. Suppose it's a TALL, where you can't use blina, you can't use another. What you do? So whatever I understood from the discussion, that even low dose, so they agree when there is MRD positive, they do upfront transplant, results are not good. but many people does. So that is the understanding I get from the T. So that is the whole understanding about my understanding about that. So what Vinay is saying, I fully agree with this. It's very difficult and toxic. I used a couple of patients I used up to 2016, 2017. Then I changed my strategy because adult patients 40 plus high risk block. Have you ever tried the Vinay high risk block with the 40 plus patients?
No, sir.
I tried. I'm very
Actually,
honest. I tried 2
yes.
times. I have a very bad experience.
Actually, honestly, most of the time when we use HR block, that is in the IR patients, that means 18 to 40 years, not beyond 40 years. And
Young
most of the
patients,
time, even those patients who remains MRD positive or not having this hematological response, then we straight away go into even Plaga-Ida before if the patient is a transplant candidate.
Dipendu, the whole world is saying nowadays a little bit moving with this, that whatever protocol you use, try to achieve MRD. If you are not able to achieve MRD after a certain point, say after a post-consolidation point, so they try to move to immunotherapies, either Blina, whatever available is. I'm not talking about a cost here. I'm very honest to you.
Yes.
Blina
Yes.
cost of bomb because we are using recently, we know. So we are getting the drug outside and all these things. So there are issues. So that is the thing. So I have seen some practice. I'm very honest to you. There are some people that they give some induction phase 1. So Bina, your comments, huh? So MRD is not very greatly achieved, and they immediately move to hyper CVAD. So how is your experience with this hyper CVAD protocol?
So,
in
sir,
your you are a
I-
fan of it. You are not using it. What?
now, sir, a very, very personal experience. Last
Yeah,
year,
yeah,
I
you
lost.
personal experience only. Yeah, just personal experience. We're chatting here. We are not
I
doing presentation.
I lost my first cousin to BALL last year. He was BALL, PBALL.
Hmm.
So he was upfront offered hyper CVAD. He was intermediate risk group, and none of the molecular markers were positive on NGS. Cytogenetics was normal, pre-BALL. With hyper CVAD, because in hyper CVAD doesn't contain L-asparginase,
Correct.
he could not achieve MRD negativity even after 2 cycles of hyper CVAD.
But
Uh,
A and B, right? We're talking about. But
A,
hyper
B, and then yes, A, B, and then again A, B.
okay, so
MRD
total
was
4. Yeah, by 2 cycle, yes. 2 yeah.
and then he was given inotuzumab based salvage.
Hmm.
Then he underwent allogenic transplant, but he had bad VOD. It was a haplo transplant, and we lost him. So that is one personal experience with hyper CVAD. And then when we tried to analyze in retrospect, probably now there were some opinions, international opinions on him that because it doesn't contain L-asparginase, it may not be a very good regimen to begin with.
Yeah, I agree with that. I've seen a lot of people believes, there is a philosophical belief, there is no data with a VFM versus hyper CVAD. They feel that hyper CVAD always works better. But I don't find any rational and science behind it. Are you with me or are you against me?
What we find that in adult patients, the L-asparginase is very difficult to tolerate for these patients. Most of these patients develop some of the liver
Side
toxicity
effects.
with L-asparginase. So that is the
That discussion, I'll do that because that is my next agenda. So my understanding is that if you convinced about that BFM, follow BFM. If you're convinced about the hyper CVAD, follow hyper CVAD. But I've seen there are a lot of people that say that hyper CVAD is a more stronger regimen, more better regimen. Somehow I don't agree with this. Somehow, yeah. So I just come to the next question. So Bina, I start with you. So L-asparagines, adult ALL, do you follow any age cutoff or dose what you do in your practice?
So, sir, in my practice,
You use BFM, right?
yes, I use BFM.
Yeah. That how
So
you do.
I use intense BFM without any modification until patients who are like 45. After 45, I use less of L-asparginase, but until 45, I use same thing, 5,000 units per meter square during induction 1A, and in
So
reinduction.
So you use the conventional ALS.
Conventional, yes, not the.
You give around 8 to 10 doses, right? In
Yes,
induction.
yes,
Perfect.
yes.
Dibendu, yours?
We have started using PEG asparaginase in inductions, and honestly, in pediatric patients there is not much problem, but in adult patients, even at the age group of 35, 40 years, we get some of the patients have toxicity.
What dose you give? What dose?
For PEG asparaginase, it is around 10,000 unit. Sorry, 1,000 unit per meter square.
1,000 you give, yes.
1,000 unit per meter square.
Yeah, so I am extremely careful. More than 50, I don't use asparaginase. 40 to 50, I little use asparaginase. I use pegylated asparaginase, and I use only 1,000 unit per meter square. I don't go beyond 1,000. That is the only dose I use. And that I'm very careful. If I feel something going wrong, I just skip the second dose or something. But yes, sometimes pegylated asparaginase can be a nightmare with a lot of side effects and the toxicity. Yes. And more than 40, more than 50, we don't use asparaginase. Yeah. So I just come to the little bit about a pH positive ALL discussion, adult pH positive ALL discussion. So start with Binay. So Binay, when you think about a pH positive ALL newly diagnosed, so how you treat? You use TKI, right?
Yes, sir. Sir, I usually
yes,
yes,
please.
I usually add TKI after 14 days, after first 2 weeks.
You add little, yeah.
Because I've seen that once you add it from day one, it leads to a lot of cytopenias, and then giving.
Day one तो तुमको मिलेगा ही नहीं, because report आते ही तो 4-5 दिन लग
Yes,
जाएगा.
usually report is available within 72 hours. मतलब flow आया 2 दिन में वो पूरा fish panel PCR panel आ जाता है. If it is positive, till I wait for 2 weeks and then I add TKI. First 2 doses of donorubicin are done, and then I add TKI.
You use dono, right?
Yes.
You use dono.
Because it's a part.
Sorry. Yeah, please.
It's a part of BFM.
Okay. Dibendu, what you do? You use dono, pH positive.
Yeah, in the patient right now, the shift in the treatment protocol is that in case of a Philadelphia positive ALL, you try to achieve a hematological response and the best MRD negativity that is that you can achieve, and then go for transplant. So whatever you can do. So in most of the patients, what we start with a steroid, vincristine, and TKI. And if the patient is a transplant eligible patient, then once the patient goes into CR, we directly go take the patient for transplant. So in situations where the patient cannot go for transplant, then we try to continue with the same steroid and TKI for a long durations, around 84 days. And after that, steroid is tapered off and TKI is continued. And we find that most of the patients, actually this is a lot of more of a palliative care than complete cure, but most of the patients remains in hematological response, though they may not achieve an MRD negativity, but they remains in hematological response.
So Dibendu, in adult ALL, if the patient is MRD negative, even in pH positive, would you still go ahead with transplant in CR1?
It's a my question also, yes.
So still now we try to go for transplant, even though the patient is in MRD negative, because in Philadelphia positive patients, there are higher chance of relapse. And what we find, most of the patient actually have a CNS relapse or somewhat medullary relapse at later point of time. I don't know. I don't have much experience, but we try to go for transplant.
I have few questions here. Yes. So number one, so pH positive ALL. So how you go for transplant? I mean, suppose you induction phase 1 you given, right?
Yes.
And then you give induction phase 2?
Actually, no. We after the induction phase 1, if the patient is having a hematological response, then we continue with steroid and TKI only till the patient goes into transplant.
You don't go give induction phase 2.
Do not give much chemotherapy, because with the chemotherapy there are a lot of cytopenia, and then we cannot manage those patients.
So before transplant, do you give any CNS radiation or use ITBI?
Yeah.
What do you use? What do you use?
We use Flu-Cy or Flu-Mel, or if it is a matched donor, because we don't have a TBI facility right now, so we use thiotepa sometimes. Thiotepa based.
So then how you boost the CNS then? You don't do CNS radiation also before taking them.
So No, CNS radiations, actually prophylactic CNS radiation is given before in patients who are not in transplant, not going for transplant, but in transplant, we do not, till now not using TBI.
You don't give methotrexate also, 4 doses of methotrexate.
No, actually we have done only 2 transplant for ALL. Only 1 patients who are completed right now, and the second patient is waiting for the transplant actually. So we will take it. So we have started because the patient is still not ready for the transplant. So we have started the high dose methotrexate for these patients and continuing the chemotherapy with TKI. But we are getting very difficulty because we have to wait for the count recovery and it is getting delayed. So the protocol is getting interrupted most of the time for these
What
patients.
TKI you use? What TKI you use?
We use dasatinib.
Full 100 or 50?
We try to use 100, but if there is cytopenia, then we go down in 50.
Yeah. Vinay, what is your strategy about this?
Sir, same, and I'm also using dasatinib because, as you know, dasatinib crosses blood-brain barrier in a better way as compared to other 2 TKIs. So I'm using dasatinib.
Okay. And when you go for the transplantation, you give the methotrexate block or CNS radiation, something you do, CNS boosting or something? And
Sir,
then
actually, no personal experience of PH-ALL adult transplant. We don't have TBI facility here, so I'm not doing ALL transplants here, sir.
so we had one patient, a 59-year-old. So she is basically a PH positive ALL, done very well. According to Binay, the same thing happened. Just 7 months of maintenance. Incidentally, we found that isolated CNS relapse. And then we managed with the dasatinib steroid, and then we given the methotrexate for 5 doses. And then we did a flu bell conditioning as because 59. We have TBI facility here. So I'm very fond of TBI in the ALL, no doubt about that. But I somehow feel in ALL, TBI is sorry, very important thing. But in young patient, if you do transplant, I think when you counsel that, give them the option of the TBI, whatever the facilities you have or not have, whatever. But you give the option of that, because otherwise some people can question you. Young patient, 20, 25, then site TBI is obviously the standard one. So that will be my suggestions here. But otherwise, the adult patient, 50s, 55, I think the little bit flu TBI is also fine. And sometimes we did one flu TBI, very low dose TBI, and then flu. Recently, we did one break like that. 56-year-old male, yeah. So these are the things. So both you are using dasatinib. Yeah, I fully agree. Dasatinib is a drug. What Binay told already, that crosses the blood-brain barrier, and that is the way. Yeah. So next slide. Nishan, how much time we have?
Sir, as much you want, sir.
As much you have. Then Binay may not like and Dibend may not like. They are hardcore family men. I know both of them.
I think we will probably directly go into inotuzumab.
Sir, at least 20 minutes we have, sir. We have one hour meeting, sir. So it is right now 8:40.
Yeah. So next slide.
Yes, sir. Sir, the graph is there, sir. The next slide.
Yes, next slide. That we all know bad prognosis.
Yes.
Next slide. Yeah, so when we talk about the ALL relapse, obviously previously when we don't have any option, we used to do the standard flag idea salvage regimen. So we have now better, easily manageable salvage regimen. Blinatumab we don't have in our country, but inotuzumab in the country. And I think irrespective of the finances, inotuzumab will be the drug of choice. Right, Vinay, you agree, no? Right, no doubt about that.
Yes, sir.
Salvage.
We have also used inotuzumab in one of our patients, and it's really wonderfully improves the counts, and patient becomes completely clear with inotuzumab.
It's a good drug, no doubt. So one thing is very important in the inotuzumab, that what I say, mazak karke main bolta hu, within 2 cycles you get the result, whether in this side of the fence or that side of the fence. So first of all, your logics will be very clear whether a patient will go for the transplantable or not transplantable. So when you know the transplantable, most of the responses happen in the 2 dose. If 2 dose or 3 dose doses response is not happening, that means it's not happening. And if the patient is not transplantable, then 6 doses is the standard dose, 6 cycles is the standard dose we do. Next. So yes, it is a highly curatable option. And what is the most important thing is that there are many patients. I told before my starting this discussion that only 10% of the 10% of the relapsed patient get some form of treatment. So this is the only drug which is a fantastic bridging drug, making the patient in remission again, and then you have option of the transplant the patient, which is a beautiful consolidation, and which definitely increases the curability of the patient. So that is the most beauty of this drug. Next. So what is the goal of treatment in adult refractory B-cell ALL in your opinion? So both is a, yeah, so obviously when you're treating for the salvage, obviously your cure should be in your mind. Next. So Vinay, I come to this very straight question. What is the goal of treatment in adult relapsed refractory B-cell ALL in your opinion? MRD negativity, best treatment in fast salvage status and high disease burden status, and HSCT curative approach. So how you want to rate this whole thing?
So if patient is a transplant candidate, of course, goal of treatment would be MRD negativity followed by transplant. If patient is not a transplant candidate, say, then it would depend on age and patient's physical fitness. So probably then it would be improving progression-free survival and overall survival.
So suppose after 2 cycles of the anituzumab, patient MRD is still positive, what you do then?
So if it is still low positive, I think I would straight away go ahead with allogenic transplant in the hope that GVL will give some, will play some role there.
If the money is not an option, will you try Blina before that?
Should. I think then we should.
Yeah. Because recently I'm managing one case. I'm seeing post-transplant. Actually, he's under my care. So my colleague did actually the induction phase 1, badly failed. Anituzumab to some extent worked, but MRD still positive. Then Blina 2 cycle, MRD negative. They did a transplant. They use a regimen, what is basically a fludarabine ATG TBI. They use a regimen, and now I'm just following for the now it's day 36 or something. Actually, patient is from Bombay. They went to Delhi and then get a treatment there and then back here. So I'm managing the post-transplant scenario now here. So I somehow, so that means the 2 options we have now with the money is not the issue, that Blina and anituzumab. So no options are there. I agree. Finance is a big thing, but I think these 2 are the very important thing now. Yeah. Next slide. Next. So it is very well proven that anituzumab achieved higher rates of CR and then MRD negativity. And it is definitely better than conventional chemotherapy like a FLAG-ID or whatever you want to use. I have seen some patient previously used to use the hyper-CVAD in the relapse setting. So I think the anituzumab that way. And one more thing, there's a lot of data about the anituzumab and the mini hyper-CVAD. So that is also very exciting. We are giving one patient now with a anituzumab with a mini hyper-CVAD concept.
So it is like immunochemotherapy combining.
Yeah, that's good. And if you see the mini hyper-CVAD doses, no, the doses is not so horrific doses.
Right.
So doses are, yeah, and it's manageable. Manageable. So single agent anituzumab and mini hyper-CVAD. So now what happens, there are a lot of options open now. So you can choose according to your patient profile, according to finances, according to, so these are the options. I was reading some recent data about the Blina plus INO combination. Very small data, but there are combinations. So like that. So there are a lot of options now open. So I think that 10% patients only can do some form of treatment in relapse setting in adult ALL. That probably, that notion is totally out now in 2023. What is the best part of this medicine? Next. Yeah, next. So MRD negativity was achieved in the majority of responders within the 2 cycles of the anituzumab. So you're within 2 cycles, so 2 months, you know that exactly where you are. You are negative or positive, and then you can plan it for the thing, whether you do transplant upfront, whether you can use some other agent or whatever you want to do. So you know that. So if the patient don't do well on the 2 doses of the anitumab, you need to change something. So that you have to decide. Next. So MRD negativity is associated with overall survival benefit. Yes, that is there. So obviously when the patients are MRD negative, they have a transplant, their overall survival definitely increased. And then you can see it from these graphs. Yeah. Next. And survival was improved in MRD negative patient treated with anitumab. Yes. And it is now everywhere. This is the first salvage choice, what I say. Whenever you relapse, you need to some salvage. So anitumab in our country, it is a drug of choice. Yeah. Next. Next. Yeah. So INNOVAT trial, we all know, is a very well tolerated trial and it's a very manageable side effects. Yeah, I just come 2 or 3 side effects now. Next. Next. So I already told that it is the first salvage. This is the best option. Dipendra, you agree with me?
Yes, if the finance is not a problem, then obviously anitumab is the best choice in some.
Vinay, you also agree with me, right?
Yes, sir. So very practical question, sir. How and where do we place anitumab? And when patient has relapsed, say it's early relapse, very early during maintenance, and we are planning to give anitumab, how do we start it, and with what chemotherapy regimen should we start it, or it's a single agent drug?
You know, I am somehow you can choose with a mini hypercvad with the anitumab, or you can
Okay.
choose the anitumab individually.
Okay.
Problem happens at 2 questions. So anitumab single agent, you can get away with a OPD basis, daycare basis. But anitumab mini hypercvad, you can't. You have to, patient has to stay in the hospital. And the costing is a very important thing here. So these are the 2 things you have to very careful about that.
So my questions will be whether it depends on the WBC counts at the time of relapse or nothing else.
I don't think so. WBC count is important here because you know your marrow is, if the disease is in the marrow, so counts whatever may be. So you have a say 1 lakh count or 1,000 count. As a hematologist, we don't bother, right? We know that marrow is full of blast. So I think the tolerability of the patient. As relapsed patient, one thing you know already, if you know the patient performance, right? What he had done in the last 3 months, 4 months with you, whether any previous fungal infections, bacterial infections, every cycle is come with MDR, Klebsiella, but that group of patient, obviously we choose the anitumab single agent, right? And if the patient is fit, never all the time is a culture negative febrile neutropenia, whatever happened, you don't have any bad bugs in the body. I think there you can combine the thing. I think it's a patient profile you have to understand better. I don't think you should go with the counts or anything. Absolutely. Yeah. Next. I think so. Whenever I take any patients with me, which is actually not my patient, now many patients come for only transplant. I have to study the patient very carefully. I take the files. I spend at least 5-6 hours with the file, try to understand the patient very well. So here the individual personalized care comes big way. That which patient you do what. Suppose your salvage patient is not salvaged, then your entire purpose of treating the patient actually we missed, right? So you have to be very careful. Doing some heroic attempts or something, you have to be very careful about it. And what I do in my practice, I study my entire file. I given my ID physician also 1 day file. You just go through and tell me, and then we jointly decide what the regimen will follow. So we do is a very comprehensive manner nowadays, and that we are getting a very good result for that. Our sibling other transplant also antibiotic usage are very less nowadays. Honestly, for this all these approaches, what we do, we start planning much ahead before taking the patient. Next. Next. Next, because these are already we all covered. So when we talk about the anitumab side effect, always we talk about a VOD. So your experience with VOD, Vinay?
Yes, sir. That is what I told you. My brother had VOD, cousin had VOD.
So you face the trauma of the VOD, right?
Right. He had VOD on day 9, and then we lost him on day 11. He could
Yeah.
not engraft. So the I mean the duration between use of inotuzumab and then transplant was around 6 weeks. So really don't know.
Yeah, and then so what regimen they used in the haplo?
I think he was given. I'm not sure what regimen they used because it was done at Pune. I'm really not sure what regimen was used.
Yeah, they say that you should not use the two alkylators together. That is, the
Right.
recommendations are very strong.
Right.
Yeah, and then yeah, VOD happens sometimes. It's really bad VODs. Yeah, I agree with you. I've seen one recently, but inotuzumab. But I took the same patient actually. That inotuzumab and then blinatumab and then transplanted. He also had a VOD. Now it's getting better, much better. But VOD is always a nightmare for any transplanter. Yeah, and suddenly patient when he become very sick. Suddenly patient become very sick. Yeah. So any experience with a defibrotide?
No.
I also don't have. I'm very honest. They're available in Bombay freely, but I don't have any experiences. I'm lucky enough so far. You, Dibendu?
No, I don't have any experience regarding a transplant post inotuzumab, and regarding VOD also, I don't have till now. I don't have any patients who went into VOD. Actually, one
You are
patient
lucky
had.
with me. You are
Yes,
lucky
he
like
had.
me.
Yes, yes. Only one patient who had developed some liver toxicity, but was managed conservatively.
Yeah, so I had some presentation in the VOD, so I was reading a few things. And one thing I only realized, Dibendu, you went to Vancouver, right?
No, no, I didn't.
Sorry. So in Vancouver,
Bina-
Bina, you went, no?
Yes,
Yes, sir.
yes.
Yeah, you remember? They used to give the heparin injection. You remember?
Yes, sir.
Yeah. So I asked these questions a lot of times with the Kevin. So Kevin told me, Sanjay, I don't believe in that, but it's a group's decision. That is why we are continuing the heparin injection.
Right, because there, I think the change of they stick to protocols. They immediately don't deviate from the protocols. Whatever group decides, they
Yes.
stick to that.
So I asked the same question to Dr. Nantel. Dr. Nantel also told me, no, I believe some of the heparin works. So I never seen in many our colleagues do the heparin.
Right.
She probably use heparin, if I'm not mistaken. Day -7 to day -2, something she should use. She told me once.
Okay.
And obviously the weight-based Udilib is always a good drug.
Right.
Defibrotide, yes, sometimes it works, but when VOD sets in, bad VOD, severe VOD, I think the 50% match is over. That is the whole thing. I think that is the only little drawback with this drug, VOD. Other side effects are all manageable side effects. I don't think so anything here. And when we use inotuzumab, we always give the Udilib prophylaxis. That you guys give, or?
I think it should be given.
I have used only one patient, but I have not used Idlib during the anatosmab therapy. And the patient actually went in.
I think it's better to give. Very simple drug available everywhere.
Yes.
Yeah, better to use, whatever I understand. Because I had some presentation with anatosmab a few months back, so I read all the time, that point of time. I think better to use that. Simple drug, no harm. Yeah. Next. So yeah, these are already we discussed. Next. 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 So definitely it improves survival and irrespective of the bone marrow blast count. So that is the question comes here. That cytopenia or cytosis, whatever is there, salvage and inotuzumab is very basic drug. And in our country where the blina is not there, so obviously the inotuzumab is clearly the winner. Next. Next. So safety profile, yeah, that is, we all know that. I'm not going into the details. It is manageable in the daycare, but if febrile neutropenia happens, you have to manage accordingly. Next. Next. So what is the long-term overall survival in your treatment setting? So any particular experience, any particular adult ALL patients, whenever he comes in front of the OPD, you are very excited all the time. Oh, you are still doing well. Anything like that? Anything we want to share?
Yeah, yes, sir. There are few patients where
So
Because
share one experience. Yes, share
when
one experience.
somebody with ALL comes into their 4th decade, they start their treatment at 40, and we are really not sure about their long-term survival. But thus, there are patients. I started practicing in Indore in 2016. Now it's 2022, so almost 6 years. So I have a couple of patients who are, sort of who walk in with sort of they are like a pleasant surprise to me. They are just on regular, 6 monthly follow-up. But there are a couple of patients like that.
Dibendu, anything, any particular patient you want to remember?
I'm not that much lucky because here in Raipur, I'm working for last 3 years. So still now I don't have that much patients who are actually adult patients and surviving more than 2 years. I don't have any.
So I just share one experience, quick experience. One lady, 66-year-old female, 2013, pH positive ALL, very fragile, but very, very conscious lady. She's very decked up, hairstyle, parlor, everything, very, self-respect is too high. I just given imatinib and very low dose steroid. No maintenance, no LP, nothing. Tried one dose of vincristine, she started getting the tingling numbness, and still she blames me for that. So like that, no marrow, nothing. Then this course finished, no marrow, nothing. I just put him on imatinib 400. Now she came to me just to wish Christmas, December 2022, few days back. She comes every 6 monthly with good counts. I don't know what is there in the bone marrow. I never tried to do that. Only imatinib 400 is on and nothing else. So 2013 and now it is 2022, 9 years. Every time he comes, I really surprised that probably the era of the personal medicine is really needed. Another patient in Indore only, I know also, no, not from, Indore only, because Nima is treating. The gentleman is 66-year-old, again 66-year-old. He's a Pandit, very senior Panditji. He had a relapse 2 times with little bit of 6MP, little bit of methotrexate, little bit of nilotinib, little bit of LP with methotrexate. He's still alive today, almost 1.5 years after second relapse. I don't know what is happening. So these are the 2 things I really, I sometimes feel that sometimes if you don't do much, it helps much probably. Yeah. Next. So that we all discussed. Next. So most common adverse effects we discussed already. Next. Yeah, next. BOD already we discussed. Next. I think Nishant, you have done. I think all are the same slides.
Yeah, sir.
Yeah. Anything, Binay, you want to add or something? Something we just
takeaway would be probably we should start. I know not each and everyone who comes to us can afford inotuzumab, but probably during counseling we should now include inotuzumab for each and every patient. At least during counseling, we should give them an
I'll tell you one thing, Binay. If you calculate the INO cost and everything, and then daycare, and if you compare that cost with any conventional chemotherapy regimen with inpatient cost,
supportive care,
so the difference will be not much.
Exactly.
And patient morbidity more with the conventional one.
Right, sir.
So initially patient may say, oh, so much cost I can't bear. But you have to, when you explain this to them, they will choose the other way around.
Right.
Depending anything
also the perspective must change actually, that after the relapse it's only a palliative therapy. That is not the scenario right now. We have a lot of options.
Yes, options are opened up, absolutely. Because honestly, when I just preparing the data, ALL data that about that relapse ALL, Dr. Biagwal told me present these, and kya present kare, kuch hai hi nahi. So then I just gone through only 10% patients. Then I realized all these options. So that, yeah. Thanks, Nishant. We done already.
Yeah, sir. So thank you very much, Sanyal sir and Vinay Vora sir and Dibendu sir. Thank you very much for excellent moderation and panelists for excellent discussion, sir. Sir, today we have almost 24 colleagues across India, 24 doctors who have attended this meeting and enjoyed the feast of scientific sessions, sir. So on the behalf of whole Pfizer family and all doctors who are attending session, I would like to say you thank you. Thank you very much, Sanyal sir, Vinay sir, and Devendu sir.
You should have been telling me, no. Other, I just do the chatting with them.
But it was a learning experience because we don't have much experience. Subha Prakasda already have a lot of experience, so we actually learn from him also.
No. You guys
Yes.
are doing fantastic work. Vinay is doing fantastic work, and you are also doing fantastic work. खबर आ जाता है मेरा पास.
सर आप ही से सीखा है. We are just following your footsteps.
नहीं ऐसा कुछ नहीं है. You guys are doing fantastic job. Fantastic job. Chalo, have a good night.
Okay, good night, sir.
Good night, Binada. Thank you.
Yeah. Bye bye.
Thank you very much, sir. Once again, sir. Thank you.
Thank you.
The family, sir. Yeah.